call on the coronavirus. This is Congressman Mike Levin, and I'm so grateful to you all for joining us again on this Saturday afternoon. And once again, we're honored to be joined by a local expert, infectious disease epidemiologist from UC San Diego, Dr. Richard Garfien. I'll briefly summarize Dr. Garfien's background. Truly a leader in his field, a healthcare innovator who seeks to understand the causes of disease and translate that understanding into impactful solutions. Earned his PhD at Johns Hopkins and his MPH at San Diego State. Served as Epidemic Intelligence Service Officer and epidemiologist for over 7 years at the Centers for Disease Control and Prevention in Washington before joining the UC San Diego faculty in 2005. His research focuses primarily on airborne and bloodborne infections, often associated with health disparities and substance use, including tuberculosis, HIV, and viral hepatitis in the US and abroad, as well as digital adherence technology, which over the last decade informed the CDC and World Health Organization guidelines on the use of telehealth for remotely monitoring patients with tuberculosis, telehealth being so incredibly important for COVID-19. Dr. Garfien, as always, it's great to see you. Thank you so much for joining us.
Happy to be here.
So as has been the case over the last couple of weeks, we're going to spend the next 90 minutes or so providing you with the latest updates on health information as well as policy information so that you are better informed about this virus. And of course, it's become just so incredibly tragic to see the numbers rising every day. Unfortunately, it looks as though the month of April is going to be a very, very difficult month for the United States. So I know that we'll all be as strong and resilient as we can be, that we'll stay home, that we'll follow the guidance and the direction of our federal, state, and local public health professionals, as we always will do, and that we certainly encourage all of our friends and family to do the same. If you have questions for us, please send us an email at townhallquestions@mikelevin.org. Again, that's townhallquestions@mikelevin.org. We'll get through as many as we can, and if we don't get to your question, we will do our best to respond either via email or at next week's town hall, and we'll be doing these on Saturday afternoons for as long as this crisis is ongoing. Some updated numbers, and I've been following and having daily meetings with the public health communities in San Diego and Orange County, and the numbers are quite tragic. The U.S. has the most confirmed cases in the world, with over now 300,000 and counting, and we've got over 8,100 deaths. To put the 300,000 number in perspective, number 2 and number 3 in the world are Spain and Italy, both of which have slightly less than 125,000 cases each. So if you add up number 2 and number 3, we still unfortunately have more cases in the United States than those two countries combined, although Spain and Italy both have more deaths than the United States. California has 12,639 cases and now 285 deaths. And as of just an hour or two ago, San Diego County is now over 1,000 cases with 1,112. Orange County has confirmed 786 cases. There have been 17 deaths in San Diego County and 14 deaths in Orange County. One metric that we're looking at, and I think everyone, including Dr. Fauci and Dr. Birx and others are looking at, is from the University of Washington. That model from the Institute for Health Metrics and Evaluation, or IHME for short, projects that 93,531 Americans will have died of coronavirus by August 4th, 2020. According to that IHME model, 5,068 of those deaths are projected to be in California, with peak hospital resource use on April 26th. The California Department of Public Health is suggesting, however, that peak hospital resource use, including ICU beds and ventilators, will be more like mid-May as opposed to the end of April. And I speak every day, as I said, with public health experts in San Diego and Orange counties, and I think that they're doing an excellent job overall, and I think we are ahead of the curve compared to much of the United States and much of the state of California. And there are some early signs that I'm sure Dr. Garfien can discuss later, that some of the early indications are that the social distancing measures in San Diego County are having a positive effect. As you know, if you've been following, last week on Thursday night, I flew to Washington to pass the most recent CARES Act, a $2 trillion bill that followed two other bills, one that we passed on February 25th and another one March 18th. Between the three of those bills, I hope that it's provided at least some Americans with relief during this incredibly difficult time. We're going to need a fourth bill to begin to provide additional relief and stimulus as we move forward, and we've already seen some of the gaps in the third bill. Very briefly, what the third bill was designed to do was to confront the two huge crises that we're dealing with at the same time, the public health crisis and the economic crisis. And really the only way to solve the economic crisis is if we effectively address the public health crisis. So what the bill is designed to do, the CARES Act, lots of money to frontline medical professionals, $100 billion to hospitals. The president just said that that would include money to reimburse hospitals to pay for those who are uninsured to be able to be treated for coronavirus. We also sent $16 billion to the Strategic National Stockpile to try to help with supplies of personal protective equipment, or PPE, along with ventilators and masks. And regardless of what Jared Kushner may say, we intended as Congress for that money to go to the states and the localities and the public health agencies that needed the materials and the supplies the most. And that's what we're committed to, is to making sure that those supplies get to where they need to go. We also funded the Defense Production Act, and I'm encouraged that the president has started to use the Defense Production Act in a more aggressive manner to procure things like masks and like ventilators. I think we need to be seeing more of that, frankly. And then $4.3 billion in direct funding to public health agencies. And that's part of a broad $150 billion to state and local government, including about $15.3 billion to California. And so I'm encouraged by all of that as well, although we already know it's not going to be enough. The governor has already said that we're going to need more for California, and certainly that's true in New York, if you hear the updates from Governor Cuomo there. To deal with the economic side of things, there's some significant pieces of the bill. One is expanded unemployment insurance from 26 weeks to 39 weeks, an extra $600 a week on top of baseline unemployment benefits. There's also direct cash payments of $600 and $1,200. The $1,200 is if you make $75,000 a year or less, and then it goes down if you are making between $75,000 and $100,000 a year. If you are a electronic filer with the IRS, you should be receiving a direct deposit from the IRS around April 13th. That's about 60 million Americans. Thereafter, 5 million people a week will be receiving their checks, paper checks from the IRS. And what's frustrating about that is if you just look at the calendar, some people won't be receiving checks all the way until August and September, which I think is far too late. So there's also a big program under the Small Business Administration, the Paycheck Protection Program. That's for small businesses under 500. They can apply with their current small business lender. There are 1,800 lenders in the SBA's approved network of lenders. And it's to cover 8 weeks of expenses up to $10 million. And the loan is fully forgivable if it's used at least 75% for payroll and the rest for other overhead and other utilities and other expenses, and if it's used within the prescribed time period, an 8-week time period. And it can be used retroactively to February 15th, meaning if a small business let workers go, they could use these funds to rehire those workers back so long as they meet the other covenants in the loan. There's also not going to be an income tax hit through loan forgiveness for the 2021 income tax year, and the interest rates for these are extremely low. It's really designed to work as a grant, a forgivable loan, so long as the criteria are met and the terms and conditions are met. We do know that different lenders are on a different calendar with regard to actually making those funds available to their customers. And clearly, the SBA needs to ramp up its efforts in the next week. I would encourage you to go to sba.gov for more information on the Paycheck Protection Program. In addition, there's a program for emergency grants of up to $10,000. You can apply for both the Paycheck Protection Program and the $10,000 grant program. There are oversight and accountability measures in the CARES Act, but I don't think they went far enough. But nonetheless, they went further than the administration desired. And they're really twofold. One is an independent, at least supposed to be an independent inspector general, although we now know that the president wants to nominate one of his attorneys to serve in that role. In addition, there's a 5-person committee that's supposed to oversee those funds. The House is also now committed to creating an oversight, special select committee on oversight, akin to what Harry Truman did while he was a member of Congress, hopefully saving taxpayers a great deal of money as we oversee and make sure there's no waste, fraud, and abuse in how that $2 trillion is spent. I'd like to finally address a few local updates. You probably know that our district, our communities in both San Diego and Orange County have put in place some pretty strict social distancing guidelines. It's so critically important that we follow those. They were summarized very well in an email that I saw today as stay in place, maintain your space, and cover your face. So perhaps Dr. Garfield could talk more about that. They're significantly more restrictive than they were a week ago when we spoke to you last, including the closure of our beloved beaches and our parks in most of the district. There is some good news with regard to testing. And, sometimes I'm asked, when is life going to get back to normal? And for me, it all depends on not only flattening the curve and seeing things coming down in terms of the number of new cases, the number of deaths, but also if testing is available at wide scale. As Dr. Fauci said a couple days ago, and I quote, "We better be careful about declaring victory just because you've turned the corner on a curve. When we turn the corner and it goes down, we have to have in place the ability to do the kind of containment that's pristine. Namely, you test like crazy. You identify people, you isolate them, and you do contact tracing." So that's really what it's going to take. It's going to take broadly available, widespread, rapid testing to eventually get us back into a situation where we can begin to get back out there and restart our economy in a meaningful way. UC San Diego is doing a ton with regard to testing, and in general, they're really a leader. They've got now, starting next week, the new fast testing from Abbott, and they're working with Roche and a number of others to try to really accelerate that. And in Orange County, I can tell you that Memorial Care is opening the old hospital in San Clemente, which has been shut down for a while now, as a drive-through testing site. And that'll be done, I understand, in the next couple of weeks. And I'm very pleased about that. The sooner, the better. So with that, again, I'll turn it over to Dr. Garfield for an opening statement. And if you have questions, please write us at townhallquestions@mikelevin.org. Dr. Garfield.
Thank you very much, Mike. That's a lot to take in. There's so much happening so quickly. I think at this point, I just want to touch on one new issue that's come up that I think is going to be on a lot of people's minds, so at least hopefully, and that is that last night the CDC posted new recommendations advising that people wear a cloth face mask when they're around others. And so I want to just sort of go through a little bit about what that means. So first of all, there's two reasons to wear a mask. One is to prevent infection by stopping inhalation of the virus, so protecting yourself. The mask can stop the virus from being inhaled and prevent infection. The other reason is to prevent transmission of the spread of the virus to other people, and that's typically through by trapping droplets that might come out when somebody coughs or sneezes, or even talks. And what's really interesting is that there was a outbreak in south of Seattle where a large number of people got infected. It was a choir group that all met. Nobody was sick at the time. At least nobody knew that they were sick. And over half the people that were present ended up getting coronavirus infection, and 2 of them died. And it turns out, we actually knew this from tuberculosis, that when you talk, the vocal cords vibrate, and that actually creates sort of a reed, and it could actually spread virus just through the air. But when you sing and you're projecting your voice out, it's actually a much more effective way of aerosolizing virus and transmitting it. So we've seen outbreaks of that with tuberculosis, and now that's one example of where it's occurred with coronavirus. So we can't just think about the droplets, but that's the primary route of transmission, is these bigger particles. So wearing a mask, if you're infected, even if you don't have symptoms yet, you might be infectious, but not have symptoms yet. You can still transmit the virus. And so wearing a mask when you are infected will actually protect others. And so there's different kinds of masks. And just to sort of reiterate that quickly for people, there's the N95 respirator mask that people talk about. These are designed to filter out very, very small particles, almost down to the size of the virus itself. So the very, very small airborne particles would be captured. And these are used by doctors mainly when they're performing very high-risk procedures where there's a high probability that the virus will be aerosolized, like when they're putting in a ventilator on a patient or taking it out. Most of the time in the hospitals, doctors and staff can wear a surgical mask. These are also very good at blocking particles, but they can allow some of the very small particles through, but they're much more comfortable to wear, and they're perfectly acceptable for more routine procedures in a clinical setting. What the CDC is talking about now is a cloth mask, which is basically a homemade mask that you can wear with the intent really to prevent somebody who's infectious from spreading the virus to other people. And the reason this is so important is because based on what we've learned from the outbreak in China and now in the US, is that people can actually be infectious 1 to 2 days before they ever start to develop symptoms. And some people may never develop symptoms or just have mild illness and not even know that they're infected and infectious. So what this new recommendation is intended to do is really to sort of help us. There's times when social distancing is just not really possible, like when you're at the supermarket. If you're wearing a face mask, it will help to prevent the transmission from you, even if you're not symptomatic, to other people. Also, the reason why it's important to use these homemade masks is that we're still having a shortage of surgical masks and N95 masks in this country, and it's absolutely critical that we save those for the healthcare providers. They're the front line. They're the ones that are going to be taking care of us if we do get sick. And if they get sick doing their jobs in the hospital because they can't get enough protective equipment, then they're going to become patients themselves, and there's not going to be anybody there to take care of the rest of us. So please, don't hoard those masks. If you have access to them, call your local hospital and see if you can donate them. But in the meantime, for us to wear these homemade masks would really be very helpful. And then, so how do you do that? So there was a great article in the New York Times today on how to make a homemade mask. So I recommend going and looking for that. There's probably dozens of other sites and YouTube videos that you can look up. So just Google how to make a mask. And then there's also been a nice article that was published on smartairfilters.com that actually tells you what are the best materials to make a mask out of. The closest thing to a real surgical mask is a vacuum cleaner bag. Next to that is dish towels. And after that is cotton blend t-shirts, followed by linen, silk, 100% cotton t-shirts, and a scarf. So when you get down to the scarf level, it'll block about half of the particles. When you get up to the vacuum cleaner bag, it's about 86% of the particles will be trapped. So that's a nice article if you're trying to decide what to make your masks out of. So I think we all have to continue to do our part. It's important that we maintain social distancing, even if we're wearing these masks, because there's still potential for leakage. And the mask is designed there really to help us to prevent the transmission of the disease in the community. So I encourage everybody to look at those recommendations if you haven't already, and please do follow them.
Thank you so much, Dr. Garfien. Really appreciate that. We have a bunch of questions, so we'll try to get through as many of these as we can. And again, please, if you have questions, it's townhallquestions@mikelevin.org. And incidentally, on our website at mikelevin.org, we've got a whole bunch of resources there with a lot of national, statewide, local links, links to different nonprofits that are doing great things. So please check that out as well at mikelevin.org. We'll start the questions from Joan in Encinitas. Joan asks, why are senior group residences, such as assisted living, independent living, memory care, etc., allowed to employ staff who do not have paid sick leave? It is obvious to me that people who do not have paid leave will come to work when sick and subject this vulnerable population to infectious diseases. What can be done about this? Well, Joan, it's obvious to me too, and you're absolutely right. And know that in the second bill, which was about a $200 billion bill, the family's first bill, we did provide additional paid leave to the American workforce to about 87 million Americans, up to 87 million Americans, according to an analysis at the time by the Ed and Labor Committee of the House. Subsequent to that, in the CARES Act, we tried to do dramatically expanded family leave and sick leave, and we unfortunately, Senator Mitch McConnell, rejected that proposal. And so the expanded leave that I would have liked to see, that many of my colleagues would have liked to see, didn't make it into the final bill. But your point is extremely well taken. That is something that we're going to fight for very hard in the fourth stimulus bill, because you're spot on. You're right. Dr. Garfien, here's one for you. This is from Richard. From Larry.
Larry.
You're Richard. From Larry.
At least last time I checked.
That's right. From Larry in Orange County. Larry asks, will we not all get the virus? Only hope is to delay past peak or until a better treatment is found, correct?
Well, in theory, that is correct. Everyone is susceptible to becoming infected because this virus is new to the human population, and no one that we know of has any innate natural immunity. So yes, in theory, that would be the case. However, by practicing social distancing and other measures, we're able to slow down the spread of the virus, which then gives time for scientists to develop and test vaccines, which could protect people who haven't been infected yet, and also to develop potentially treatments that could prevent the or decrease the severity of the illness if you were to get infected. So, and if we're really effective at that, and the congressman mentioned that Dr. Fauci talked about testing like crazy and isolating and then doing contact tracing, this could actually be effective after we get a better handle on who has the disease. Kind of like what we did with smallpox, or I shouldn't say we, because I wasn't around at the time, but what scientists did with smallpox is they got the numbers down low enough that as soon as they found a case, they were able to go around and vaccinate everybody around that case, so that then the virus had nowhere to go, and it eventually just died out and it was eliminated from the population. We have the potential to do something like that with COVID-19. It was, we think that's what happened with the first SARS virus. And I think if we all do our part and, keep the science moving forward, we have a good chance of beating this one before we do all get it.
Thank you for that, Doctor. Dirk in Carlsbad asks, Trump is saying he wants his own signature on the relief checks that will soon be sent directly to Americans. This is wrong in many, many ways. Can he do this? Please, can this be prevented? Thanks for your hard work on behalf of your constituents. Well, Dirk, I agree that it's highly unusual for the president to sign those checks. Normally it would come from a civil servant or whoever would lead that check processing office at the IRS. I guess to go back to what I said originally, we expect about 60 million of these payments will be made via electronic direct deposit for those who are filing electronically, file their taxes electronically. They'll not get a check at all in the mail. And then after that, there'll be 5 million checks, paper checks every week. We do know that the president has indicated that he wants a signature on it. But at the end of the day, my concern is not so much what the signature is as the fact that the checks ought to get to people before the administration is proposing. If they do 5 million a week, we're going to be in August or September by the time people get their checks, and that's just far too late. So we're going to push to get those checks to people far sooner than August or September. I really think they need to be out in people's hands in May and in June at the latest, in my opinion. But thank you for the question, Dirk. Next is for you, Doctor. This is from Doug in Oceanside. Ignoring fatalities for the moment, how does COVID-19 compare with the normal flu regarding the need for hospitalization times and intensive care? What would be the typical length of stay for both? How many days after symptoms present themselves does severity max out? The point of my questions is to emphasize or not that COVID-19, even when not fatal, can be severely disruptive and expensive. Great question, Doug.
Yeah, it really is. And I know a lot of people have asked that question or similar questions about, why are we so upset about COVID-19 when more people die every year from the flu? And frankly, that's because so many more people actually get the flu. If the same number of people got COVID, they get the flu every year, we would see about 10 times more deaths from COVID than from the flu. And so I think that's important to realize. So just a couple of those, there's a lot in that question. So let's unpack that a little bit. First of all, there's similarities and differences between COVID-19 and the flu. Firstly, COVID-19 and the influenza virus have similar disease presentation. That is, they're both respiratory diseases, which present a wide range of illness from asymptomatic to mild through severe disease and death. Secondly, both viruses are transmitted by contact, droplets, and fomites. By fomites, we mean surfaces that get contaminated with the virus that then somebody touches and then self-inoculates with the virus. As a result, the same public health measures, such as hand hygiene and good respiratory etiquette, such as coughing into your elbow or using a tissue, are really important for preventing the spread of both. So in terms of differences, for one, the speed of transmission is an important point that we have to consider for the two viruses. Influenza has a shorter median incubation period, and by incubation period, we mean the time from infection to appearance of symptoms, and a shorter interval, which is the time between successive cases. So from one person getting it and developing, becoming infectious and then infecting somebody else. And so the serial interval for COVID is estimated to be about 5 to 6 days, whereas for influenza, it's about 3 days. So, it takes a little longer for the cycle to go from person to person transmitting COVID than it does for influenza. Also, influenza could be spread during the first 3 to 5 days of illness, and that could actually include the period when people are pre-symptomatic, don't even know they have it yet, which is a major driver for influenza transmission. In contrast, we're learning from our past experience so far with COVID-19 is that it can be spread from people about 1 to 2 days before symptom onset. And so because that period is a little bit shorter, it's not spread as easily from asymptomatic people as it is for influenza, because that period of time before people know that they're symptomatic is a little bit shorter. And then in terms of sort of your questions about the severity of the illness and who gets it, there are some differences between influenza and COVID-19. For example, with influenza, children are important drivers of the influenza. Sorry, let me get back to transmission. Children are important drivers of influenza transmission in the community. Kids get sick, they practice terrible hand hygiene, they cough and sneeze everywhere, and they are the little virus shedders, and so they're a big driver of the of transmission. Yeah, Mike can appreciate that.
I can relate to this. This is great.
Yeah, you can vouch for me, huh?
That's right.
However, for COVID-19, initial data indicates that children are less affected than adults, and that the clinical attack rates in people below 19 years are actually quite low. So it's older adults, people that are developing symptoms, that are more likely to be transmitting the disease to others than from kids. Now, when we talk about the severity of illness, both diseases can cause mild to no symptoms all the way up to severe disease and death. For COVID-19, to date, about 80% of people with infection will have mild or asymptomatic infection. 15% will have severe infection that would require oxygen, and 5% would require critical care, such as being put on a ventilator in an ICU. These fractions of severe and critical infection would be higher than what we would expect for influenza. And then finally, the highest risk for disease for influenza, the highest risk for having severe disease from influenza, the groups tend to be children, pregnant women, the elderly, and those with underlying chronic medical conditions, and people who are immunosuppressed. However, with COVID-19, from our current understanding, it's really people with older age and people with underlying health conditions such as heart disease, diabetes, and immunosuppressive diseases. So there's some differences in who's actually impacted. And then really importantly is the mortality. COVID-19, among those people that are infected right now, it's believed that 3 to 4% will die, whereas with influenza, it's only about 1 in 1,000 cases of influenza will die. So COVID is a much more severe, has a much more severe outcome. So to get at your question of, is this disruptive? Yes, it absolutely can be. I get the flu shot every year because I got the flu once about a decade ago, and it knocked me out for at least a week, and I can't afford to give up a week. I'd much rather get vaccinated and be protected. And even if I do get the flu, the vaccine helps to minimize the symptoms. This can cause that same kind of an illness. Even though a lot of people would be mild, the symptoms are fever, cough, body aches, a lot of the same symptoms as the flu. You're going to feel terrible. You don't want it. If it doesn't kill you, it's still not going to be good to have it. So it is disruptive. Also, if you're infected, you should self-isolate for 1 to 2 weeks. So that's going to prevent you from being around other people for that period of time. And obviously, once we get back to, there's so many things we've talked about in terms of the cost. It's very, very expensive. And even when we get back to normal life, it's still going to affect our ability to return to normalcy for a while. And so it's going to have a big impact on the economy.
Wow, thank you so much. A lot to unpack there, obviously, Doctor. And, one of the real breakthroughs for me was, getting my 7 and 6-year-old to wash their hands regularly, which it finally took that town hall on Nickelodeon. I don't know if you saw that they were doing that, but they did like a kids town hall, and they watched that, and then, they knew that they needed to wash their hands. So this is huge. This is a big deal.
That's great. We're going to stop a lot of diseases with this.
That's right. There you go. Great question. Also from Ann and Dana Point. And we'll talk about telehealth a little bit. And I know that's a specialty of yours, Doctor. But Ann asks, how can Congress help to get Medicare, Medicaid, and private insurance to reimburse telephone visits for patients? And I assume she means all the telehealth. We put a bunch of money in the CARES Act for that very purpose, because we know that telehealth is so critically important, particularly when you have a lot of doctors and a lot of their patients that just are going to be following the social distancing and the stay-at-home protocol. That to the extent that they can see their doctor, over a meeting interface like this, what a fantastic development that is. We made it so that a lot of different things, health savings accounts, you can use health savings accounts for telehealth. We broadened the authority of HHS to allow telehealth to be covered under Medicare. We allowed federally qualified health centers to furnish telehealth services to Medicare beneficiaries. And I'd like to see a lot more of this, frankly, in the fourth bill, because I think particularly in the coming months, telemedicine, just like we're all working from our homes, I think a lot of doctors are going to be able to do the same and still provide really high quality care. Doctor, as a pioneer in telemedicine, anything you'd like to add?
Well, I'd just like to say that it is definitely going to be the way of the future. I read that last week UCSD had more telehealth visits than they actually had people seen in clinics. And when this is all over, I think people are going to be used to that, and it's going to actually make life a lot more convenient to be able to talk to your doctor over the phone or by video and get a prescription filled without having to actually go into the clinic. So we're heading that way. I think, Congressman, as somebody who is potentially going to be impacting legislation on this, I think we have to be really careful and very deliberate in terms of patient security and confidentiality.
Mm-hmm.
How do doctors share this information with each other in a safe way? How do doctors communicate with patients in a safe way where that information is not being disclosed unintentionally? There's a lot of concern about that, a lot of uncertainty. I think we're relaxing the rules a little bit right now because of this emergency, but when things start up again, we get sort of back to normal, I think we really have to reconsider what is the appropriate level of security and what should and shouldn't be allowed to happen so that we maintain everybody's proper privacy.
That's a great point. It's a great consideration. Absolutely right. Question for you, Doctor, from John, who is an instructor at UCSD. So I have no idea whether you know John or not, but here's John's question. For me, the single most troubling COVID-19 trend is the steadily rising death rate / falling recovery rate as shown on Worldometer's website. Have we a good explanation or understanding of this? Is it as bad as it looks, or are there confounding factors to be considered?
Well, thanks, John. I don't think I know you, but maybe at some point we'll run into each other on campus. Thanks for that question, and I appreciate that because I hadn't seen the Worldometer website for COVID, and so I looked that up and I found it very interesting. So it might not be as bad as it looks. According to the WHO, based on available preliminary data, the median time from onset to clinical recovery for a mild case is about 2 weeks, and 3 to 6 weeks in patients with severe or critical disease. And so since the number of new cases is increasing every day, and it's rising dramatically, most of the reported cases that you see on that website and we're seeing on other websites are the new cases, and these are people that are still sick. So within a couple of weeks, what we should start to see is that those people that were sick today are going to be recovered in a couple of weeks, and so the number of recovered cases is going to start to rise. And so pretty soon, when we look back after this epidemic is over, we're going to see that the recovered cases will match the epidemic curve for the active cases, minus the number of people who unfortunately die and don't recover. And so, if you look at, for example, China, their epidemic is mostly over, at least from what they're reporting now. And so the number of recovered cases is close to the number of their cases that they've actually had. Since we're on the upswing, obviously we're going to have more cases that haven't recovered yet, but over time, the number of recovered cases will increase.
A related question, and this is just my own curiosity. We've had now 300,000 cases, give or take, in the United States. We've had about 8,100 deaths. And in Spain and in Italy, they've had far fewer cases, but more deaths. What do you attribute that to? Is it that we're doing something better in terms of the hospital capacity, or just the nature or the timing of how this is spreading? I guess what do you attribute that to?
Yeah, I think that things will change over time. When we look back, we're going to have a better understanding of how the epidemic unfolded in each of these countries. It could be that the very high mortality rate in Spain and Italy might be due to the fact that they're not testing as many people. So the relative proportion of people who die compared to the number of cases is going to appear higher. In this country, we're starting to do more testing, so we're counting more cases, and the proportion of those cases that die will be less. Now, that's one explanation. The other explanation, obviously, is the quality of healthcare and the ability for doctors to keep people alive. It could also have something to do with how long people wait before they actually get healthcare. If they only come into the emergency department when they're already in a very severe stage, they might have less of a chance of survival once they do get into the hospital. So there's a few different variables that go into that question, and I think we'll have a better understanding unfortunately, after the epidemic is over and we have a chance to go back and really assess the numbers.
One of the other statistics that is really, I think, very important to understand is the dichotomy between the United States and South Korea, where both countries found their first domestic case on the same day, but now the United States has over 8,000 deaths, and South Korea has less than 200. And so just kind of looking at the two countries and the difference in the effectiveness of containment, the expanded use of testing, the simplicity of the type of testing being used in South Korea as opposed to the very complicated types of testing that we've done here, some of the early issues with the CDC and the reagent not working, and the FDA not doing what necessarily maybe they needed to be doing. I could go on and on. There'll be plenty of time to figure out what went wrong, but I think the key now is that we really have to, as Dr. Fauci said, we have to ramp that testing up before we can figure out a path forward. Here's a political question, more of a political question from Mark. The Trump administration China tariffs have been costing businesses and consumers millions. Isn't their elimination an obvious place to start for economic stimulus measures? Well, I opposed these tariffs even before the pandemic. I think that they were really reckless in many ways. I think they've hurt businesses in Southern California, and that includes in our district. I've heard from business owners about that. So I'm glad that the administration is waiving some of those tariffs, or at least has indicated that they're going to do so. And I hope they continue to do that, and not just when we're in a time of crisis. This is a question for you, Dr. Garfield, from Teresa, who is a physician assistant in Encinitas. Teresa asks, many of us rely on home health care providers to provide essential care to our elder patients who are in isolation in their own homes. There are tasks they are well trained to do, i.e. bathing, toileting, etc., that if we tried to do, we could injure ourselves. Please comment on your thoughts about permitting home health care providers into a private home or an isolated senior with mobility issues. Thank you for donating your time and expertise.
Teresa, I appreciate your gratitude, and I thank you as well for being on the front lines as a physician's assistant and doing your part. So you make a very good point about the challenges of an untrained person trying to do the job of a licensed home care provider. I think it's really important that people get the quality care that they need. So if a home health care provider are taking the same precautions that other healthcare providers take to protect themselves from infection, as well as protecting their charges by not going into work if they're sick and wearing a mask to avoid transmitting the virus if they're asymptomatic, they should be able to continue performing this important function. So I can't speak for Occupational Safety and Health Administration, so I think it might be worth looking at their website and seeing what their guidance is on this. But like any other healthcare professional, I think home healthcare providers should be able to perform their duties as long as they're taking the same types of precautions that you would when you're seeing patients in a clinic.
Thank you very much for that. Another question from Chris in San Clemente. Chris says, I've been living in OC for 3 years now. There doesn't seem to be a lot of information easy to access with what our local governing folks are doing. How can I get that? Well, Orange County actually does have a pretty good website where they have all of their up-to-date information, everything from the cases and the numbers of cases in different zip codes, different cities, things like that. They have a lot of answers to frequently asked questions. San Diego County, of course, has great websites that have the same info. I think the all that information will be on mikelevin.org. You can go on our website, and we'll have links to Orange County and San Diego counties' respective websites. They also have a hotline as well in Orange County, 833-426-6411. Again, that's 833-426-6411. And then the other thing that I highly encourage you all to do is, depending on where you live, you can sign up for text alerts from the respective counties. I get text alerts from both counties, and those are very timely and usually have a lot of good information. Another question from Andrew in Oceanside, and this is kind of related to what we were talking about before. Everything I've been able to read about other countries' response is that those with the highest success rate engaged in immediate and widespread testing of their citizens. Our testing in the United States is ramping up, but it appears that the testing is somewhat disparate in that different states and even counties within those states are using different testing protocols with different response rates. Is there anything being done at the federal level to standardize the testing and reduce turnaround times? It seems to be a critical point. Thanks and well done. And you want to take a crack at that first? I've got my thoughts, but I'd like to hear the scientific perspective before I offer the political one.
Yeah, very good. I'm happy to tag team with you here. So there's a couple of things here. One are the reasons for different tests. Given that there was this great demand for tests that didn't exist prior to the pandemic starting, so even back to when the first cases were being detected in China in December, everybody jumped on board to try to come up with new tests. So normally the CDC would take responsibility for this, and they did their best to come up with a test and get it out there. It had its limitations. The state and local health departments have now been given authorization to develop tests in their own laboratories, which they're now doing, and those are ramping up. And then private companies have been brought in to help to see what they can develop and get those tests out into the hands of users. When you think about this, we're talking about, a test that's going to be used on millions of people around the country. This isn't something that's just used on a limited, number of the population. This is something where we would like to be testing virtually everybody in the country. So the amount of tests that need to be put into laboratories is tremendous. And so if we waited for standardization and to say that there's one test that should be used and everybody should do the same, one, there'd be competition for the resources to make those tests, and two, the process to get a standard that everybody accepts would take a long time. We will eventually get there. As we get more experience testing people, we have more data on the sensitivity and specificity or the accuracy of these tests. We'll be able to, the CDC and the guiding agencies will be able to make better recommendations as to what are the best tests and what labs should be using. But in the meantime, there's such a demand for tests that I think that's why you're seeing differences in the types of tests and how long it's taking for the turnaround time on the test, and who's being offered those tests. The second thing I'd like to just add is that in terms of the ability for hospitals and other labs to do the testing, each of these tests requires not only the reagents to actually do the test, but also the equipment to run them on. Some actually require highly specialized equipment. And in small labs that might only do a few of these types of tests in a week, they might only have a small device to do it. And so they're limited to how many tests can be run. The bigger labs are actually working very hard right now to set up larger equipment or a number of multiple versions of the equipment so that they can do massive testing and really improve the throughput in order to increase the rate at which these tests are being done.
When I guess this is a follow-up. When you say massive testing, I've seen the numbers like 750,000 to 1 million a week. Do you think that's about right, or is that in the realm of possibility anytime soon?
I couldn't answer to that. I would love to love to have the answer. I think we're trying to get up there, and and we should definitely be increasing, but I'm not sure exactly where we're at.
There was an article yesterday in the Washington Post called "Inside the Coronavirus Testing Failure," and it was pretty striking. And just to read a little bit from it, on January 15th, a leading scientist at CDC assured local and state public health officials from across the nation that there would soon be a test to detect a mysterious virus spreading from China. And 3 weeks later, on February 8th, one of the first CDC test kits arrived at a public health laboratory. By then, the virus had reached the United States, and the kits represented the government's best hope for containing it. Well, that was still possible. Then, as we've read, and as this article says, the test didn't work right. For hours, lab technicians struggled to verify that the test worked. Each time it fell short, producing untrustworthy results. In the 21 days that followed, the administration continued to rely on the flawed CDC tests. Many lab scientists eager to aid the faltering effort grew increasingly alarmed and exasperated. And that's when, over that time period, the FDA began ramping up the availability, and not just the availability, but the sounding the alarm, as I've heard from the private companies, that, hey, the CDC test is flawed. One of the chemical compounds doesn't work properly, and we need the private sector to step up. And so that happened, but it happened late, and we lost 3, 4, 5, 6 weeks in there that could have made a huge difference because we relied only on that one CDC test as opposed to earlier opportunities for the private sector, whether it be Abbott or Roche or Genmark or these other companies, now Thermo Fisher, to innovate and to come up with the best test. And it sounds like in hindsight always being 2020, things could have been done sooner to sound that alarm, but they weren't. The other thing that I'll point out is that same article that I mentioned that quoted Dr. Fauci talks about, actually quotes a professor at Indiana University School of Medicine who says, once the rate of infections has been slowed by social, really physical distancing, only a testing scheme far beyond our current capabilities can prevent another surge in infections. If we're going to get out of lockdown, we need to radically improve our testing protocols and infrastructure, and we need to do it fast. So all that leads back to what has Congress done? Congress has sent a boatload of money to the relevant agencies in order to accelerate the deployment of tests all across the board. And we're finally starting to see progress, but we're woefully behind. And, that's the only way we're going to get out of this social distancing and all these draconian measures is if we have the tests to be able to move from a mitigation strategy back to a containment strategy. And we have to do it soon as we can. Fair enough?
Yeah, and if you don't mind, there's something I'd like to add a little more to that, which is it's complicated to decide who should be developing tests. The CDC and our government realizes the importance of public health, and so we have a CDC, and we're very lucky to have such a esteemed agency. I can't speak for the CDC. I'm no longer with them, and even if I was, I'd probably have to get everything cleared by them. But just to give a little bit of insight, the CDC has highly trained scientists that are used to working with these kinds of diseases on a regular basis. They also have laboratories that are at the highest level of containment so that they can work on highly pathogenic, highly infectious diseases in a safe way. And not very many labs around the world have that capacity. So if something new like SARS comes along, they could put it into those kinds of laboratories. They could do the appropriate research. They can get the information out quickly. And that's why oftentimes they're the first ones to develop these kinds of assays. Now the question comes like, why don't we give that to the private sector to do? Well, if you look at SARS-1, from 2002 to 2003, that virus started circulating in Asia, and it looked like it was going to be really bad. And so we could have spent a lot of time and money ramping up and developing all these tests, but it actually petered out, thank goodness. And And there really wouldn't be a market for that today. So if the private sector invested a lot of money in developing that test, they'd be sitting on a lot of tests that wouldn't be used today. So you can see there's sort of a tension here between who should be developing the test. Is it the public sector to protect the public, or is it the private sector that really can only do that if they have a guarantee of return on investment? Otherwise, they go out of business. So I think it's really kind of this public-private partnership where, you know, if the CDC figures out what's needed and kind of gets the ball rolling, and the private sector says, okay, I can see where we can play a role here, and they pick up some of the burden of developing the tests and commercializing them and making them more widely available, I think we can address these problems. But I think a strong public health infrastructure supported by the government is just absolutely vital for us to be able to respond quickly to these emergent threats and be prepared to do so.
Thank you for that. That's really outstanding. Next question from Joe in Vista. Oh, I like this one. Why can't Congress set up online sessions in times of emergency? Well, Joe, they can. We just haven't yet. You know, the Congress is a 230-plus-year-old institution, and it's sometimes reluctant to want to change. I know that many of my colleagues would like to see some sort of secure remote voting. There's been talk of even, you know, putting a remote voting system, whether it be a laptop computer or something like that, securely in each of the homes of members of Congress on a temporary basis. We're not talking about forever, just until we get through this crisis. And it would require a change in the House rules, and that change in the rules would require a vote itself. Therein lies the problem. And the issue there is we would have to get a unanimous vote in order to pass a rule change. And if anybody objected, then we would have to physically be present in the chamber in order to vote for the rule change. So this is exactly why we all had to go to Washington recently for the CARES Act, because one of my colleagues took it upon himself, Tom Massey of Kentucky. He didn't like the bill, and he thought it required, he wanted to see a roll call vote. So he took it upon himself to ask us all to come back, or he you know, really in his actions demanded that we come back. And then many of us flew back that had no intention of flying back. Literally 4:30 or 5 o'clock on Thursday is when I found out I had to fly to vote to make the quorum in order to pass the bill. Far too important to not allow that to happen. And I was on a plane 3 hours later, wheels up, a red eye to Washington, D.C. But I have followed Dr. Garfein's advice since then, and I haven't left the house, and I feel great, knock on wood. So there you go. What I would love to see happen is the next time we have a vote in the House, and we don't know when that's going to be, we ought to strongly consider voting on a rule change as well to see if we can't, throughout the duration of this, institute some sort of remote voting. And of course, the other consideration is that the most recent predictions of the Washington, D.C. area suggest that their COVID peak will come quite a bit later than a lot of the rest of the country. They're talking about late May or early June for the DC area. So that's a consideration as well. It throws a lot of things up in the air scheduling wise. But you know, what we've been told is to expect a full schedule. We're going to make up as many of these lost voting days as we can. And, you know, we're supposed to have district work period in the month of August and the month of October. And it'll be interesting to see what happens with regard to the schedule. Question for Dr. Garfein. I heard that, and this is from Janice, I heard that the FDA approved the new 15-minute test. Do you know when we can see those in our area? Will we have to be sick to get one? Good question.
Yeah. So Janice, that test is actually in San Diego. I know that UCSD is starting to run that test, and I think they're planning on doing several hundred a week. I think they're trying to get up to about 1,500 a week, last I heard. And so they are available. Now, your second question is, will you have to be sick to get one? At the moment, they're going to be used for mainly two reasons. One is to help doctors to understand what it is that they're dealing with a patient in the hospital. So are there symptoms due to COVID as opposed to something else, so they know how to treat the patient? And also, if they're infectious, they're putting those patients in designated wards as opposed to the general wards. The other thing that they're using the test for is for healthcare workers to find out if they're infected, to make sure that if they are, they're not treating patients. They're very high risk of becoming infected, and they need to make sure that the workforce is adequately tested. However, as Mike mentioned already, is that Dr. Fauci from the NIH is strongly advocating for increasing testing and being able to test everybody. So at some point, our hope is that tests will become widely available for people with and without symptoms, so that we can really understand the extent of the epidemic, and so that we can identify people who are infectious, even if they're not experiencing symptoms, and get those people into isolation so that they're not transmitting to others, and we can get control of the outbreak. So at the moment, the tests will be restricted to those that need it most, but the goal is to be able to get more testing out so that everybody can be tested.
Thank you for that, Doctor. The next question was from Terry. Terry asks, why are only some beaches closed? State beaches in San Diego County are not. Look at the Surfline cameras, they are packed. If you don't close all the beaches, you are causing crowding at the ones left open. My understanding, Terry, is that as of last night at midnight, pretty much all the beaches are closed in San Diego. Not pretty much, all the beaches are closed in San Diego County. So we must have gotten this question earlier than midnight. But you're right. I mean, that's basically what was happening. And, I think we've seen social distancing, to the extent social distancing measures have been voluntary in different parts of the world. People don't always comply with them. And we also have some research that we can talk about the merit of the research. But Kim Prather from Scripps, I know, has said that, the ocean is not the best place to be during a virus or during a pandemic, because the virus might be able to have a greater ability to stay in the air and stay in the water than perhaps in some other places. That, of course, will require more testing to prove that thesis out. But nonetheless, that's another data point. I would go to your city's website, as we said last week, to kind of understand what's still open. I know that, some places have nothing open, and other places have things like trails or certain limited public spaces that are still open. But wherever you do go, please exercise good judgment and follow all the social distancing guidelines, because as the doctor has said repeatedly, you still can, even if you think you don't have the virus, you still can transmit it, and it can be asymptomatically transmitted. So please stay careful out there. Here's a question for Dr. Garfien from several people. What kind, and this is one that you've answered before, so I know you're an expert at it. What kind of precautions should we take when bringing groceries and produce, as well as newspapers, into our home?
Yeah, good question. And before I get into that, I'll just confirm that the San Diego beaches are closing. I drove by Torrey Pines State Beach, which was one of the last places that surfers can go, and it was completely shut down this morning. They had lifeguards and police patrolling to make sure that people weren't going out. So, and this isn't unique to San Diego. Beaches all around the world are closing. Costa Rica, which is a very popular surfing destination, has closed their beaches. And I think what was really responsible of the World Surfing Association is that they've stopped all the surf contests around the world. They don't want to have these professional surfers traveling around the world, potentially spreading virus or picking up virus in other places in order to compete in these contests. So it's not just us here in San Diego. We're all trying to do our part to make sure that we contain the virus. So going back to your question about how do we bring things home safely from the grocery store, including things like newspapers, So the best evidence so far comes from a study that was published in the New England Journal of Medicine that indicates that infectious virus can survive on cardboard for up to about 24 hours and on plastic and stainless steel for up to 3 days. Now that doesn't mean that if somebody touches something, it's going to remain infectious for that whole time. The virus degrades over time, and it can be degraded by things like heat and how much humidity there is in the air and exposure to UV light from the sun. All these things can degrade it. So from the time it contaminated, the amount, the quantity of virus that can cause infection is degrading. And so so just because it can last for a day on cardboard, it doesn't mean that there's going to be quantities of the size that can cause infection. But we still want to be very careful. So what I do is when I go shopping, I gather up all my groceries, I get to the cashier, I pay for it, put the groceries in the bag, and take them out to my car. Because now my hands have touched everything in the market, and I don't know who's touched it or coughed on it, the first thing I do is I use my hand sanitizer and I clean my hands before I get in the car. That way I'm not, contaminating my steering wheel and everything else in my car. Plus, the whole time I was in the market, I make sure I'm not touching my face. Then when I get home, I take the groceries out, and there may be things like fruit that have been handled by people more than some other items, and so I want to be careful with those. So I put my fruit and vegetables in the sink with a little bit of soapy water, give them a good rinse, and then I'll put them away in the refrigerator after that. For other products, if there's a box of cereal, for example, you can take the inner package out of the box of cereal, throw away the box, and just keep the inner bag. Even if somebody at the factory touched that bag, by the time you got it, any virus that was on it is dead. If you have other items, before you put them in the refrigerator, you might want to wipe them off with a disinfectant wipe, so jars, cans, things like that. And the other thing you could do is I actually, with a lot of my canned goods, I just left them in the garage for a couple of days. I figure, I don't need them right now. They don't need to be refrigerated. They can sit in a bag for a couple of days, and they'll, any virus that's on them would degrade. So I think we want to be careful when it comes to bringing items home from the store. We don't know who's touched them, who sneezed on them. We want to be careful. We want to wash our hands after we've touched them, but we don't want to go too crazy with this. You're at much higher risk of coming in personal contact with somebody else who's infected and breathing in the air after they coughed or sneezed.
So, doctor, you've given me something to do. After this town hall, I need to go take my my Cheerios that I got in the delivered, Honey Nut and regular, and take them out of the boxes. Except I worry that my kids are not going to know which is which, and they're going to take all my regular Cheerios, and they don't like them. They like the Honey Nut. I like the regular. They like the Honey Nut Cheerios, but that's a good idea.
Yep.
It's a very good idea.
All right.
So next question from Mary in Dana Point. I am a CPA who specializes in working with small businesses. It would be really nice if someone would consolidate all the details on available programs into one place so I can make sure that my clients are taking advantage of everything that can be offered to them. Well, we have tried to do that. I hope we've succeeded. And Mary, again, if you go to our website and you click on the COVID information, we have it all listed there. Now, for the small business programs, I would go to sba.gov. I just went on there today. They have a lot of information about both the emergency program and the PPP program. The challenge with the PPP, that's the loan, the forgivable loan, that's really between the lender and the small business. And what we're hearing about different lenders, some of them are doing a great job and others are not doing such a great job. So hopefully all the lenders will be offering those programs or that particular program very quickly. Dr. Garfien, this one's from Rick. When do you okay, so it's a multi-part question. Number one, when do you anticipate the peak for San Diego County? And number two, how long after the peak would we need to maintain social distancing? Great questions.
Yeah, well, there's a number of models that are trying to figure out exactly that when that peak will be. And, as the congressman mentioned, it looks like towards the end of April is when we might see the peak here in San Diego. I've talked with colleagues at UCSD, and for planning purposes, they're expecting that in the next 2 weeks or so, they're going to start to see a big increase in the number of cases that are going to be coming into the hospital. So I think it's coming. What we've been able to do, though, I think pretty well, is with social distancing and with people really being careful, we've been able to keep the number of infections somewhat lower, and maybe we'll be able to push out that peak even further and keep it from getting too high. The point I just sort of like to make, rather than trying to speculate, when the peak is, and I think there's lots of reasons to want to know why, when and why there's a peak, and that is, for planning purposes, but also to know when we can sort of get back to life as normal. And I think there's a couple things to consider when it comes to the social distancing part. First is that social distancing is actually helping to slow the spread of COVID-19. And without it, the peak would occur quickly, and it would be very, very large. The higher the peak, the quicker the epidemic would end, obviously, because if everybody got infected all at once, it would end. But that also means that the healthcare system would be overwhelmed, and a lot more people would unnecessarily die from COVID. So we don't want to have that happen. Social distancing helps to flatten out that curve, which actually makes it take longer to reach the peak. It'll take us longer to get there. It'll take the peak will be slower, longer, and it'll take longer to get past it. But it keeps the infection rate low enough that the healthcare system can keep up with it. And so that's important. A couple other things to consider is that if social distancing ends too soon, the case counts will go back up. So if we see that the cases are going down and everyone says, great, it's over, and we all go back to what we were doing, those people that haven't been exposed yet will get exposed, and we're going to see another peak, and it could be an even higher peak. So we can't just stop all of a sudden. So what we really need to be thinking about is, how do we carefully phase out social distancing? We kind of have to be thinking about this now as to, what do we do? We can't just have the president order that the pandemic is over and we're all going to go back to life as usual. This is going to take a real concerted effort to phase back in certain industries, certain jobs, certain activities, and then have a surveillance system in place to actually monitor to see whether or not cases are starting to occur in those populations again. If they do, we have to be prepared to quickly pull back, reinstate some of the social distancing measures that we have in place to get it back under control again. So it's going to be sort of a monitor and see and be able to respond quickly to what's happening. The other thing is that when we do go back to work, things aren't just going to be normal. We're going to still probably have to have some protective measures in place when we do go to work, such as maintaining some social distance at work, hand sanitizing more often, sanitizing the environment more often, because we want to make sure that we don't have those breakthrough cases coming after we go back to normal.
And the difference, I presume, is just lots and lots of testing, right? Because we tried, originally a containment strategy in January, and clearly didn't work. where I know we tried to contain the people on the cruise ships and the people coming from China, although there's some dispute around that, and tens of thousands of people have come from China since the order was put in place to try to stop people from coming from China. But nonetheless, we tried a containment strategy. We then, when containment didn't work, we had to shift to mitigation, social distancing, stay at home, and all the rest of that. So I presume we'll want to go back to containment eventually, but we'll want to do it with the benefit of widespread testing so that we can have far more effective containment.
Exactly.
And that's, as Fauci said, got to test like crazy. So we got to get those tests ready. So Linda asks, this is a great question. I work at the VA. It's a very sad question. I work at the VA and have been told that if we want to wear a mask, we have to bring our own from home. We want to work, but everyone should have the option of wearing appropriate PPE and having that provided. What are you doing for more masks, PPE, and ventilators? How can you make the medical facilities have the PPE for all healthcare providers? Well, first of all, let me just express my gratitude to you, Linda, for the work that you're doing on the front lines of this. It is entirely unacceptable that any hospital, much less the VA, would not have a PPE for you. And particularly given that as part of the CARES Act, we sent $20 billion more to the VA specifically for PPE and masks and ventilators and anything else they needed to deal with COVID. What I can tell you in my conversations with Dr. Smith, who runs the VA in San Diego, they're doing everything that they can to provide PPE, masks, and other related safety protocols. Obviously they're doing everything they can to serve our veteran community. Tragically, we've had, I believe, around 80 veterans that have lost their lives as a result of COVID, and we have frequent discussions. My staff has frequent discussions with VA leadership about the steps that they're taking. But I'll certainly take your comment back to the folks that I know at VA and make sure that everyone is getting PPE and masks as needed. The other thing I'll say, this is a problem, of course, broadly, not just at VA, but throughout our medical system. And I wrote, along with a number of my colleagues, to Secretary Azar recently, demanding that they do all that they possibly can to try to get more PPE. I mean, we're literally pleading with Azar, with the HHS Secretary, to get more PPE out and masks out. And that means using the Defense Production Act. It means using whatever tools are in the toolbox to make sure that it happens. And we're not going to stop until all of our hospitals and our frontline medical professionals have the tools that they need to stay safe and to do the job. The other thing worth mentioning is it's critically important. We're saying, stay in place, maintain your space, cover your face. Cover your face, but not with an N95 unless you're a frontline medical professional. Save the N95 masks for the people who are needing them the most, and wear a made at home mask using all those materials that the doctor talked about. Fair enough, doctor?
Yep, absolutely.
All right. Good. Okay, so here's one for you, doctor, from Katie in Carlsbad. What can be done for severe cases without equipment such as respirators? What about the staff? How can we better protect them now?
So, Katie, if I understand the first part of your question, I think you're referring to our ventilators, not respirators. And so I'm hoping I'm answering your question correctly. Ventilators are absolutely crucial for critically ill patients with COVID-19 to help them to keep their blood oxygenated. Otherwise, they literally drown. However, doctors don't monitor just their lungs. They're actually monitoring the whole patient, meaning that they're closely monitoring the patient's other vital organs like their heart and their kidneys, and they're taking every step necessary to maintain the health of those organs so that the patient has the best chance of surviving until their immune system can fight off the virus. So these steps will be taken even if there's no ventilator available. The ventilator definitely improves survival immensely, but doctors don't, it's not necessarily a matter of you have a ventilator or you don't. Doctors do have other things that they're doing to try to support the patient as best they can to keep them going long enough for their immune system to fight off the virus. The second part of your question is about, what about the staff and how can they better protect themselves? Well, healthcare workers know how to protect themselves against COVID-19 as well as other diseases that are spread through the air and through fomites. The problem they face is in following the best practices when there's inadequate supplies of personal protective equipment. And also as people working in hospitals get busier and there's more patients and things get more critical, they're more likely to make mistakes. Mishaps happen. The busier you get, the more likely it is that something, somebody will get bumped, somebody will actually accidentally touch their eye after they've worked with the patient. and that's how healthcare providers get infected themselves. So the ways that we can help here are, one, continue practicing social distancing and everything else that we've talked about already to prevent ourselves from becoming infected so that we don't end up becoming part of the burden on the healthcare system. And then also avoid using surgical masks as the congressman just mentioned. Leave those N95 respirators and surgical masks for the people that really need them to protect themselves in the healthcare setting. We can use other materials to make homemade masks that will do a pretty good job of protecting our community members from the spread of the virus. And they do offer some protection for ourselves from breathing in droplets from somebody else. They're not 100%, but every little bit helps. So I think going ahead and learning how to make a mask and wearing it when you go out is a good idea. And so the thing that we can do is to not get sick so that we can help the healthcare system to take care of the patients that really are sick.
Thank you for that. And, I want to give just a quick shout out to a couple of our local companies who are really going above and beyond and their medical device companies. They're making ventilators that normally don't make ventilators. They're doing all they can to support our local hospitals. And that's really more of what we need. It's really an all hands on deck for our medical device companies, life sciences companies, pharmaceutical companies. In many cases, foregoing planned and more lucrative business opportunities to help support COVID. And I'm really grateful to our incredibly outstanding community of businesses and organizations that are trying to support our hospitals during this. Two questions about the next topic. Yes.
I was just going to say, as long as you're giving a shout out to the local businesses, I think we can't forget the microbreweries that are actually have converted their equipment to be making hand sanitizer for
hand
the healthcare workers. So
amazing.
Good for them.
I'm a proud member. In Congress, there's a caucus for everything. I'm a proud member of the craft brewery caucus, and we've got in North County, as you know, some of the most amazing craft breweries anywhere, and quite a few good ones in South Orange County too. So that's outstanding. How could I forget? Amazing. Two questions on the next topic. Why, and this is, I've gotten this a lot, why were non-essential items added to the coronavirus bill in the House? And did the bill include raises for the House and money for undocumented immigrants? So I've heard this a lot. And no, the bill didn't contain raises for the House. It's ridiculous. And basically, anytime that you have a $2 trillion bill and you have 435 members of Congress, each of whom has their own issues, their own pet projects, you're going to get things in there that don't make any sense, that aren't related directly to the challenge at hand. That runs the gamut. And at the end of the day, you have to make a decision as a member of Congress whether you allow the perfect to be the enemy of the good. In this instance, it was clear that it was going to be an up or down vote on what was negotiated by the Senate and the House in conjunction with the Secretary of the Treasury. And I decided that I would vote affirmatively because the good far outweighed the bad with this bill. But there were all kinds of crazy things in there. There was a provision for next generation research into sunscreen because there was a company in Kentucky that, I believe it was Kentucky, that the Kentucky delegation was interested in helping out. And, there were other things for other states. And at the end of the day, as I've said, it wasn't perfect, but we did the best that we could. And I'm proud of the work overall that was done. And now we're going to need to do quite a lot more. Question for you, Doctor, from Dave in Orange County. Please discuss the various coronavirus testing capabilities that are currently available. Please include other alternative tests, new antibody ones, fever-based, etc., that are also coming online and what they look like. Please include the accuracy levels of each. The goal would be to know what's our best estimate of when ready testing for all will be available?
Okay, that's a big set of questions there. And I wish I had all the answers. But I think that these are really important questions. So there's different types of tests that are being done. There's one type of test, which was the first one that came out, which actually detect the virus itself or the genetic material from the virus. And they're used to see if the patient has the virus currently in them, and that would be an indication that they would also be infectious. If they have the virus in them, the virus could be shed, and so that's an indication that they're actively infected and they could spread the disease. And when you test a patient who had coronavirus and had illness with that same test, maybe a week or two later, and you see that they're negative, that's an indication that they have resolved their infection, they're no longer infectious. So that's the viral test. The other test that was mentioned is the antibody test. And antibodies are what our bodies produce, our immune systems produce in response to an infection. And so they can also tell you if a person has been infected, but they don't tell you necessarily if they're currently infected. But they're very, very helpful in knowing who has already been infected in the past. So once our bodies make antibodies that fight the virus, those same antibodies are what protect us from becoming infected again. So there'll be a very good tool for knowing, one, if the person's ever been exposed to the virus. So if we're trying to look at whole populations and find out who's been exposed, whether or not they ever knew it, and also who would be considered to be protected from becoming infected again in the future. Those antibody tests are very valuable. This might get a little technical, but we produce different types of antibodies in response to foreign proteins. One of them is an IgM class, and the other one is an IgG class. The IgM antibodies are the ones that show up first after an infection. So they come in very early, but they don't last very long. Then after a week or so, they get replaced by the IgG class. These are the long-term antibodies, the ones that can protect us if we were to ever get exposed to the virus again in the future. So by combining both of those antibodies in the same test, you can actually tell if a person has a recent infection as well as whether or not it's a past infection. So those tests are coming online as well. And I'll just mention, I don't have the answer to how many tests are out there and what is being used, but I can tell you that there's a company called National Bio Green Sciences that has developed this IgG antibody rapid test that can actually be done in 15 minutes, and it doesn't have to be in any specialized lab. That should be coming online hopefully soon. I just read about that one this morning. I think that one has a lot of promise. And then also Q Health in San Diego just got a $13 million federal contract to develop a rapid test that can potentially be done in the home. For now, these tests will be restricted to helping doctors determine appropriate clinical care, but and for infected healthcare workers to provide so that we can tell when it's safe for them to go back to work. But the good news is that there's plenty of people working on it. There's more tests coming out, different types of tests that can be used for different purposes. And, the world's working really hard on getting testing out. We know that the demand is there, and that these things take a little bit of time.
Thank you for that, Doctor. Just a couple more. Malcolm in San Diego asks, is it legal for Southern California Edison to continue spent nuclear fuel loading during the coronavirus 19 shutdown? Well, that's an interesting question. And the answer is yes, I think it is legal, Malcolm, but I guess the question is whether or not it's in the spirit of the governor's order to keep non-essential businesses from continuing their operations. The way I see it, and I actually wrote Southern California Edison, those of you watching this may know that I've been very focused on the nuclear fuel issues at San Onofre and really around the United States, trying to figure out how we get that nuclear waste off the coast as quickly and as safely as we can. And so I was somewhat concerned when I heard that Edison was continuing the fuel loading operations at San Onofre during the COVID crisis, because when I read the governor's order, it deemed things such as essential electric infrastructure work, like keep things that keep the lights on, things that keep electricity running in our hospitals and so forth. That's obviously essential, but moving radioactive fuel in furtherance of a decommissioning of a plant that isn't generating electricity anymore, I did not deem that as essential under the governor's guidelines, or for that matter, the federal guidelines. And as a result, my concern has been and remains that in the event that, let's say, there were some issue at the plant that would require emergency medical personnel, that you would be taking away emergency medical personnel from the COVID crisis at a time when they're already spread far too thin. So I don't see it as a necessary activity, the fuel movement. And I wrote the CEO of Edison International, and he wrote me back a letter that basically said that he was going to get me more information. Just the same, I asked him about the recent spill of 7,000 gallons of wastewater of sewage. And I wanted to seek more information about that as well. So we're going to stay on the San Onofre issues. And in this particular instance, obviously, I wanted to know why Edison had deemed the fuel movement to be an essential activity. Thank you for the question. Dr. Garfien, here's one from Dennis in Solana Beach. And this is similar to what you answered before. How do you see the rollout after we are sure we've flattened the curve and are in the process of exiting this crisis? Meter people out onto the streets by age, when and how to open gyms and restaurants, etc. How abrupt or how long a process?
This is a great question, Dennis, because it's important for us to think about a phased approach to easing restrictions. While I've not been involved in this myself, I'm confident that our health officials at the national, state, and local levels are working on this. I don't have an exact answer for your question, but here's some things to consider, as I'd already alluded to before. One is that we need to start slowly. We can't just lift the restrictions and let everybody go back to what they're doing, because we know that there's still going to be people who are susceptible to infection, and there will be people who are infected, and it will spread, and we're going to get that second wave, which is what we're trying to prevent. Also, we have to think about new ways of doing business. Maybe some people have to wear masks after going back to work for a period of time until the epidemic passes. We might need more frequent disinfecting. We might have to, alter the way that we conduct business. Maybe it'll all be with, the credit cards that you tap as opposed to, putting them in and touching keypads. So we have to think about how to do that more safely. And then it's very important that we have ongoing surveillance, so that as people do go back to work, we're watching and monitoring to see if the cases start to increase again in certain sectors of the population, because then that'll give us evidence of what's working and what's not working. And if we see something, the cases are coming back in certain areas, we can say, okay, that's not safe. Let's stop that, and we'll back off on some of the loosening of those restrictions and tighten them up again. And then we have to be prepared to reenact restrictions if the case counts begin to go back up again. I think, people have to just be willing to say, okay, the restrictions were relaxed, but if necessary, we'll put them back in. We'll go back to social distancing. We'll go back to what we need to do. And that has to be okay. We all have to be prepared for that. It's not going to be like one day we wake up and life goes back to normal. This is going to take some time to get through, and we can do it if we all work together.
Well, thank you for that. Couple more questions and we'll have to wrap up. Stephen Del Mar asks, we're aware of the SBA portal that allows a small business owner to apply for an economic assistance loan. As of Thursday, we've been locked out of it. How do we apply for a loan that is part of the new $350 billion federal stimulus package that is allotted to small businesses, and how quickly will we receive those funds? So this is the Paycheck Protection Program. that I talked about before, and you actually don't go through the SBA directly to get the loan. You go through your lender, your existing lender. There are 1,800 lenders that have a pre-existing relationship with SBA, and I hope that all of them will offer these loans. Again, the way that it's supposed to work, the way that we in Congress intended it for it to work, would be a very simple application process that doesn't consider your credit worthiness or anything like that, simply whether or not you need these funds up to $10 million in order to pay for payroll and other basic overhead and utilities and rent and things like that. And so long as you use the funds in the allotted fashion and the allotted time, then you can have all of them forgiven. All the loan will be forgiven, and you won't have to have a 1099 the following year for loan forgiveness as some sort of income or anything like that. And it won't impact your credit history either. That's the way the program was intended to work. What would be really terrific is if you are out there and you're trying to apply, let us know if you're having trouble. Our office stands ready to assist. You can reach out to us, and we'd be more than happy to help. We've got a number of our team that are becoming experts very quickly on this program, and it was supposed to be rolled out really in earnest on Friday. We know it's kind of a mixed bag on Friday with some of the lenders ready to go and others not ready to go at all. And we hope that our banks will see this as an opportunity not only to make sure their customers stay afloat, but also to do some good in the middle of this crisis. Thank you for that. Last one, Jill in Carlsbad, please comment on what more we can do as a community, even if we can't leave our homes. What kind of pressure can we put on our legislators to enact what America needs? Hope you and family are coping as well as you can. Well, Jill, I can tell you that we're doing great. Our family is as great as we can be doing. It's nice to have the time with Chrissy and the kids here at home. It's a very, very difficult time for our community, obviously, and for our country. I would encourage you, you can still call your elected officials, you can still write. We're all working, we're just working from our homes, sort of as the new normal here. But we listen to everything that all the voice messages that are left and all the emails that are written and the letters that are written. We try as best we can to get back to everybody. And I would encourage you to continue to try to weigh in on those areas that you think are most important to you. With that, Doctor, we're just about out of time for this week. And if you had any closing remarks, thank you again for just the extraordinary community service that these town halls provide. We've gotten rave reviews for all the things that people have learned from you, and we're very, very grateful. And if you had anything in closing this week, now would be a great time.
Just real quick, I'd like to say, I appreciate all the effort that everybody is putting into doing their part to keep us safe and to get a handle on the pandemic. I think that there's a lot of information. Things are changing almost on a daily basis, and I think it's important to keep up with that. I encourage people to look at reliable sites like government sites like the CDC, the state health department, the county health departments. They all have COVID on their front page. You just have to click on that link and you can see the latest information. There's a lot of information on the internet that might not always be accurate, and that could add to the confusion. So I'd say, start with those government sites. They're going to have the best information for you. And also, if things change, try to roll with that, because as the pandemic evolves, scientists and doctors are learning more about how the virus is behaving and how our efforts to contain it are working, and sometimes that requires changes. And the same thing with the science in terms of the treatments and the vaccines and the tests. That's all evolving as well. Things are happening very, very quickly. So, be patient with people, be understanding. We're all pretty new at this, and we're going to get through it if we work together. But don't go off on conspiracy theories right now. We just need to keep a level head and work together and get through this.
Thank you, Dr. Garfield, so much for that. Just a few quick comments. One, thank you to all the community members out there for the kindness and generosity that you're exhibiting day in and day out. We've had so many of our constituents that have reached out to others in need who have been able to provide assistance, whether it be financial assistance, food assistance, really an incredible amount of generosity in our community. Number two, again, thank you so much to all the frontline medical professionals and everybody putting in the work, whether they're stocking the shelves at the grocery store, delivering the mail, keeping our lights on, keeping our water systems and electricity systems operating. We are so incredibly grateful to you. And to everybody watching this at home, stay at home, stay safe. To the extent that you have to go out, please use the social distancing guidelines. And now, as has been recommended by the CDC and our local agencies, make sure that you cover your face as best as you can. I was also reminded recently that, normally I advocate for people when they have firearms in the home to keep those locked away. That's so critically important now when we have kids at home, that we keep those devices safely stored, firearms safely stored. So I hope everyone is doing that as well. I have no doubt that we're going to get through this. As we've said, Americans are incredibly resilient and incredibly strong. And I think that we will come out better from this experience, but it's going to be a very, very difficult few months here, and specifically the month of April and the month of May. And we will see how things go this week. But I have so much faith and confidence in our local medical and public health professionals. They really are the best of the best. They're working incredibly hard, and I'm grateful to them. And until we see you next week, we thank you. Please stay safe and visit our website again at mikelevin.org with a lot of resources, and we'll see you next Saturday. Take care.